Okay, hi to all. My name is Todd Streelman. I'm the chair of the School of Biological Sciences, and I want to welcome you to today's town hall presentation from two of our faculty members in the school on science and projections for our academic restart to campus. Let me first introduce our speakers. We have Professor Joshua Weitz, who is both director and founder of the Interdisciplinary Ph.D. program in Quantitative Biosciences, and then also Professor Greg Gibson, who is director of the Center for Integrative Genomics. Let me just give you a quick procedural update. We have a chat and a Q&A associated with this town hall. Please use the chat just to discuss things with one another. And if you have questions that you'd like Greg or Joshua to address, put those in the Q&A. And I'll keep my eye on those. And at the end, if we have time for questions, I'll prompt the speakers with questions. Okay, so with that, I am going to mute myself and turn the screen over to Joshua and Greg.
Okay, thanks, Todd, and hopefully you can hear me. And I'm going to begin to share the screen now. And if someone who is unmuted would like to tell me that they can see a screen.
It's good, Joshua.
Yeah, it's good.
Okay, terrific. Let me hide that little thing. Can you still see it? I just hid the application window.
Yes.
Okay, good. So thanks, Todd, for the introduction. And this is going to be a hybrid sort of presentation. Hopefully, Greg and I will focus on the science today, science and projections for return to campus. And in doing so, address many of the questions you may have, and we'll certainly reserve time for questions at the end. But we do have slides that cover both modeling concepts, testing initiatives, and issues that directly relate to the reopening, restart of Georgia Tech in the fall. Just to give some of the disclosures from the outset, in case you want to reach me afterwards, my email is listed there, jsweitz@gatech.edu, and Twitter and a web. And this is collaborative work, our work on the modeling side by many and also supported by many. And likewise, Greg, do you want to just pop in? Hopefully you're unmuted and just read off your email as well.
Yeah, so my email is greg.gibson@biology.gatech.edu. But I did want to take this opportunity to start out with just to emphasize that the testing program is a really major effort that's supported by the President's office. So President Cabrera has been behind this initiative for months now. And what he's done is put together a team. So going forward, it will be led by Mike Shannon at GTRI with the help of his colleague Mike Farrell. They are deeply engaged with the state, logistics, and just putting everything together. Two people who've been absolutely key to this are Anton Brixen and Dalia Julik. Dalia's my lab manager. Anton runs the IBB Molecular Evolution Core. They're the ones who've put the lab all together. A few weeks ago, Julianne Williamson and Alex Ortiz joined from logistics, who are coordinating multiple collection sites on campus. They're working with a team of 30 or so people. And I also have to mention that Emily Ryan has been appointed as director of the CLIA lab. And we've had enormous IT support from Arun Chand, who just graduated last Thursday, and now Brian Liu at GTRI. And at the bottom there, you can see the names of just some of the people who have been and will continue to be absolutely critical to the operations of this testing endeavor. Thanks, Joshua.
Terrific. Yeah, terrific. So with that, I'm going to begin, and hopefully we can give you some sense of the context. And I'll begin by moving back into March and April, when, as you recall, over spring break, the decision was not to return to campus, a decision made by many. In our group, we have been working on models of the outbreak since January 2020. This is just one example of some of our projections focusing on Georgia, and there are different scenarios there for a reason, meaning that what was going to happen when this was in late April was not certain. We certainly were on a a path, as you can see by this middle line, the top panel, deaths per day and cases per day, that suggested that Georgia was on a dangerous plateau with respect to community transmission. Both those green lines with respect to, let's say, back to business as usual or unmitigated scenarios suggest there are far worse alternatives, in part because we remain almost entirely immunologically naive. So there was a chance also optimistically, if you look at that lower green panel, the curves could go down, and that maybe that over the course of the summer with sustained interventions, whether it be lockdowns or social distancing and increasingly mass usage, that cases could go down, but that is not what has happened. This is an update looking through the summer up to the present day. And what you can see is that we've seen, instead of a decline in cases, a resurgence of cases up to the highest levels we've seen since the outbreak of the epidemic in terms of recorded cases, and also highest sustained weekly levels of recorded deaths per day. And you can see that also in terms of the cumulative, the break point happened here around late June or July in terms of a different slope with respect to accumulation of cases, and now we're seeing with lags the accumulation of hospitalizations and fatalities. If you go to the Georgia Department of Public Health, I'm contrasting about 1 month apart the update that they offer every day on their website with this COVID-19 status report. And what you can see is essentially half of the total reported cases since the inception of the epidemic have occurred in the past month, 40% of hospitalizations, 30% of ICU admissions, and 25% of fatalities, noting that severe cases and fatalities are often lagged behind the case reports. So the takeaway here from these three slides is that we've had time to prepare in various modes, but we also have to deal with the reality of an increasingly resurgent epidemic, in which today's talk will really focus on the science that help guide decision-making processes. A default mode of face-to-face learning where everyone comes back to campus, business as usual, is not feasible. So we'll try to break up today's talk to give you all information that informs what we believe are paths to making better decisions about how to restart. And we'll break this up into two parts. I'm going to talk at the beginning on model projections, and then Greg will talk about testing initiatives, as he's already mentioned, a significant large-scale and also sustained effort to bring tests to campus really in a comprehensive sense, and then we'll have thoughts that can open up into the discussion. And in doing so, by beginning, I'm going to really focus on the risks of this dynamic outbreak. How can individual actions and institutional efforts help reduce risk for all? In doing so, I'm going to focus on three questions. One is simply the risk of exposure. What's the chance that you may be close to someone who has COVID-19, particularly in settings that are associated with elevated risk? The next question I'll try to address is the risk of a large outbreak, to the extent to which there are imported cases, which we expect will be the case, and we expect there will be many. What is the risk that that could lead to a large epidemic outbreak in our community? And by that, I mean student, staff, faculty community, and obviously this overlaps with the Atlantic community at large. And what are then the risks of severe outcomes? How might this impact the campus community, not just in terms of cases, but obviously the thing that we're concerned most about, which are these severe infections. For context, there are many data reports out there in terms of cases. We, for a long time, have been trying to relate these data on case reports to something personal. The idea that if one has a sense of how many cases there are, this was a figure we released way back when in March, what are the odds that someone might be infected in events of different sizes? And in March, this was part of the justification for shutting down large gatherings, because as more people are concentrated in one particular area, there's a higher chance that one of those might be infected, and that could lead to new infections. The way we think about this is a very simple risk model. We all know intuitively if there's a higher per capita risk, let's say 1 in 10, then clearly groups of 10 are not advisable, or even 20 or 50 get even worse. The problem remains that even with the number of cases that there are, it may be that each one of us hardly knows anyone who seems to be infected right now or who knows that they are infected right now. In other words, there's a perception of lower per capita risk. Nonetheless, when risk becomes something like 1 in 100, then large events may still include one or more COVID-19 infected individuals, even when you might not know anyone who is sick. And I want to differentiate being sick from infected because of asymptomatic transmission. And the idea there is that if there's a per capita rate P, 1 minus P is the probability someone is not sick. So to make sure that no one is sick in a group of size n, you just have to raise that probability n times and take 1 minus. We've taken this very simple binomial probability model and applied it using a real-time dashboard, and this is in collaboration with Professor Cleo Andrus and her Friendly Cities Lab here at Georgia Tech, as well as scientists from ABLE, the Applied Bioinformatics Laboratory. And the idea is that on a county level, we take the last 2 weeks of cases reported via State Department of Public Health and aggregated via the New York Times, and then using an ascertainment bias, the fact that there's usually a 5 or even 10 to 1 number of actual cases for each reported case, to get a sense of current circulating infections. Once we know the per capita circulating infections, we can turn that into a risk that someone, one or more, individuals may be infected in groups of different sizes. Here focusing on an event of size 50, and you can go and explore this yourself. The point I want to make here, and focusing here on Fulton County is just one example, that given circulating cases, once we get into realms of even 25, certainly 50 and 100, become high probability events that one or more individuals in that group may be infected. And this is then problematic for multiple reasons. Obviously, there's an increased likelihood that someone in the group has COVID-19, and that may be asymptomatically. There's more potential interactions. In other words, the number of contact scales with n squared. This is then can be associated with super spreading events. And the vast majority of super spreading events or mass spreading events have occurred indoors in sustained interactions, whether at a conference, choir practice, and we've seen now events in schools. It's also harder to contact trace. So close contacts in a gathering are not always easy to reconstruct. And again, I want to emphasize this point that may not always be appreciated. This was from a CDC serological survey, in other words, testing for antibodies, asking the question, who has been infected, rather than PCR tests, which ask the question, who is infected and may infect others, that the CDC found that there were often 10 estimated infections per each reported case. So in other words, we take the recent cases, we multiply by this ascertainment bias, and we get a sense of risk. So what are the mitigation steps? Well, there are many. It's part of the reason in March that there was a sustained effort to reduce gathering sizes. And that should be true now too. For example, if a classroom of 25 has approximately a coin flip chance of one or more individuals having COVID-19, it raises the question, why should we have that classroom size given circulating cases? And the answer is we should not. We should try to reduce density or really move to online whenever possible. And right now the safe modality is online. But classrooms are not the only place, certainly where someone could get COVID-19, and that is a place of engagement between younger individuals and older individuals, but in other locations, which we'll come back to, dorm rooms, gatherings, dining halls, and certainly parties, all of those places are examples of circumstances where large gatherings could happen and then foster more spread of COVID-19. It's also the reason why we have worked so hard collectively, and that's student and faculty together, to try to get mask ordinances enforced in all buildings. And the point then is that mask wearing helps to ensure that even if someone is sick, it reduces the risk that someone else may be infected. And that really is something that everyone here can do together. So now that I've laid out a little bit of the risk associated with someone being in a space who may be infected, the question is, what happens next? We often think about the conditions for epidemic growth in terms of something called the basic reproduction number, or R0, which I'm sure you've heard of, or RT, the current or effective reproductive number. And you can think of this, broadly speaking, as infections per time, how many new cases per time, times the period of infectiousness. And this infections per time is a product of how many contacts infectious individuals have per time. What's the probability of them coming in contact with a susceptible, and the probability that the contact transmits the disease. And I'll return to this later. Each one of these points can be an opportunity for control. Right? If you can reduce number of contacts, if you can reduce the probability of contact with susceptible, if you can use PPE to reduce transmission, all this is going to help drive down the spread of COVID-19. To illustrate why this is challenging, here I've given a synthetic example of spread in a model. Here's R0 1.5, here's 2, and here's 2.5. I know there's an intuition out there that the disease severity scales with R0. The point I'm trying to make is that if I extend this epidemic out for a longer period of time, all of these curves can look the same at the beginning. And I want to emphasize that what we're often measuring is the speed, how fast cases double or increase in number. What we're often interested is in the size of the epidemic, how many people may be infected. And the way we go from speed to size is strength, this sort of intrinsic estimate of the number of new infections caused by a single infectious individual and otherwise susceptible population. And again, the conclusion is we often measure the speed, but inferring the strength and by extension predicting the size is harder. We've worked on this problem with colleagues, and I just want to point out again that the intrinsic R0 of COVID-19 is something like 3. There's uncertainty there, and even on the low end, something like 2 is problematic because it means that the vast majority of individuals for respiratory disease may be expected to be infected in an unmitigated scenario. Okay? So the takeaway here, with all these technical details aside, is that depending on the duration of the disease, once we measure the speed, we have this sense. But this R0 isn't telling us all we want to know. We also want to know about severity. And I want to highlight the fact, something that I think most people do understand, that the risk of symptoms goes up with age. The risk of severe symptoms goes up with age, including fatalities. This is data from a Nature Medicine paper earlier in the year with symptomatic case fatality rate on the top and relative susceptibility to symptomatic infection on the bottom. Not only are older individuals more susceptible to symptomatic infections or more likely to have them, they're also at significantly higher risk, on the order of 6 or 8%. Other studies have shown even 10% higher for older individuals with comorbidities. These are significantly elevated with respect to other respiratory diseases, and which is why there are concerns. They're not the only issues. We're learning more about other ways in which COVID-19 causes sustained tissue damage, including myocardial damage, even in silent, aka silent or mild infection. So what I'm going to do next is show what happens if an R0 in an unmitigated case of about 3 spreads with these kinds of symptomatic and case fatality rate. And the answer is as follows, and I want to be sure that I'm clarifying exactly what I mean on this slide. What I've done here is take the age distribution of students, staff, and faculty, including affiliates on campus, assuming approximately 50% of infection of the community, including the age stratified risk that I just described below, but not including any personal information or comorbidity information, just to explain the key point, that given that our age distribution tends to be on the younger side, young adults, nonetheless, interactions in an unmitigated epidemic would lead to an increase in fatalities, potentially amongst older individuals. Right? And this is something that has been concerning, whether it's in Florida, a transient spread amongst young individuals then leads later on to infections in older individuals, which then lead to more severe hospitalizations and fatalities. And these sorts of numbers, I realize, may be daunting, but they do not have to be our future, and I hope they are not. Part of the reason so many have been working so hard on trying both to understand projections, but also to take steps to make mitigants and take, whether it's testing or mask wearing, as part of our campus return, is to avoid precisely the kind of outcomes that I describe here. So what are the other kinds of severe outcomes associated with COVID-19? As I said, there can be other kinds of damages, long-term health problems, even in young individuals, extended hospitalizations. And the takeaway is that per capita, staff and faculty who tend to be older are at greater risk, but students can also have severe outcomes. And the strategy should be to take steps to reduce transmission for all. And the mitigation steps there arising from this kind of projections are that we should operate as liberally as possible with respect to starting online teaching as the default mode, particularly given community transmission. Reducing in-person interactions whenever possible, and the baseline R0 means we have to work hard to reduce aggregate spread to halt an initial outbreak, which frankly is inevitable in terms of imported cases. There will be imported cases. The question is, how do we stop those few to become many? And in some sense, I want to make sure we are in this together. We must protect each person to protect us all. And in doing so, I want to transition now to hand this over to Greg by just highlighting again the definition of R0. noting that if you want to reduce it, one of the ways you might do this is to identify infectious individuals so that they have fewer contacts. How do you do that? Testing and targeted isolation. How can you reduce the probability they interact with a susceptible? You can reduce interactions, travel reduction, there's other approaches. And how do you reduce the probability that a contact, someone in the same room for an extended period of time indoors, may transmit the disease? Process engineering, but critically PPE, including masks. And I want to do this last 2 slides as a way to gateway to Greg's portion. Classic, what is called SEIR model, susceptible, exposed, infectious, and recovered or removed. And the route without mitigation from someone being infectious is either recovery or, unfortunately, fatality. But there's another way to remove them from circulation in terms of reducing the chance that they interact with a susceptible, leading to a new infection. And that's by testing. If one tests and identifies an infectious individual, you remove them via isolation from interacting with others. You can significantly reduce R0 and then new transmission. We've run a model of this in coordination with Greg, emphasizing that here on the x-axis is the baseline R0, and this is with other non-pharmaceutical interventions, which we hope can already drive down the intrinsic spread on campus. The y-axis is the testing frequency. And you can see, I hope with my mouse, that we want to avoid these areas, unmitigated spread, infrequent testing. We want to be down in this corner. The difference here is 75% sensitivity or 90% sensitivity test. The test sensitivity, as it turns out, may be less important than speed of testing. So if we can drive down R0 to be less than 1.5, in other words, wearing masks, taking precautions, and we can test at least once a week, we're in this area over here, that it may be critical enough to reduce burden initially via entry testing and sustain identification and removal of infectious individuals to keep the outbreak small. And with that, I want to hand it over to Greg, who's going to talk about the collaborative initiatives to use testing to mitigate spread. Greg?
Thank you so much, Joshua. It's fabulous. Am I live? Yep.
You are.
Okay, great. So I'd like to thank Todd Streelman for setting this up and the College and Communications for supporting it, Joshua, his bit, and the 350 people for their attendance so far. So before I start, I actually want to make one comment, and that is I'll talk about students being tested, but our program is to test everybody on campus. So we are aiming to test staff, faculty, and students, but we'll use students just as an example in this presentation. So we have 2 goals of the testing. The first is to keep the initial infection rate as low as possible. So it's critical that we do as comprehensive surveillance as we possibly can in the next 2 weekends as students return to campus, live on campus in particular. So why is that important? Well, let's suppose we start with 100 cases on campus. So that would be something around about a 1% infection rate, assuming 10,000 students return to campus. Then if we can keep a steady state of 100 cases, new cases a week, then that will tally up to around about 1,500 across the semester, which would be less than 10% of the student body. By contrast, if we start with 400 cases, in other words, if we're unable to trace anybody, unable to remove them into isolation, then it will be increasingly hard to control. We will know this time next week what the initial rate is. I think Josh was predicting it's probably around about 1.5%, but it could be as high as 5%. Whichever it is, we need to reduce it immediately. The second thing is we want to reduce the transmission rate from that range of 1.3 to 1.5, which we think that social distancing and masks are going to get us to that steady state level of about 1.0 or less. And I should apologize, there's been a bit of a PC to Mac issue in the carryover of some of these slide figures. In any case, every fraction of R0 above 1 must be offset by mitigation of an equivalent fraction. Okay, so if you're sharing a dorm room with somebody, it's highly likely you'll get infected. If you're at a party with dozens of others, it's highly likely that super spreading events could happen. Without testing, if we start out at 100, then next week that will become 150 if R0 is 1.5. So we need to find and isolate 50 people to offset that to stay at steady state. So if the incidence is around about 1% and there are 10,000 students on campus, then to find 50, we would need to test at least 5,000 a week. So that's a minimum amount. This is not an SEIR model, but it's just an intuitive representation of why it is that really comprehensive surveillance is so important. And we decided about a month and a half ago that that was really what we had to do because the rates were going up and up, and just sampling a few hundred a day just wasn't going to get us to a point where we'd be really making a significant dent on the spread. So the conclusion there of this slide is we're going to aim for comprehensive testing at least once a week or maybe once a fortnight of everybody on campus, and starting with re-entry as many people as possible. Testing will be voluntary. We can't mandate that, but indications are from surveys and polls that the vast majority, maybe over 95% of people, are willing to participate. Next, thanks, Joshua. So one of the things that we have to obviously pay attention to is FDA regulations. And this is from a release just a couple of weeks ago that clarified the situation for everybody. There are three types of tests we need to consider. One is, so we start on the right-hand side there, there's diagnostic testing, which is what you'd get if you went to STAMPS. Okay, so that's a symptomatic individual, thinks they might have COVID-19. They will go and get an FDA-approved diagnostic test. That is done in a CLIA certified laboratory, which STAMPS has a certification for a certain type of test. And that needs to be reported immediately to the Department of Public Health. An extension of this in the epidemic circumstances when you want to actually screen asymptomatic individuals. So it turns out that anytime you take a test, a sample from a human, and want to give that result back to them, it has to be done under what are called CLIA or CLIA certification. That's an international standards. And in the United States, the FDA oversees this. So for screening testing, that also has to be performed in a CLIA certified lab. Results have to be reported to the state. And if we're going to do what's called pooling, which I'll get to in a minute, then it also has to have an additional set of validations that the tests work. Both of those cases, the rules are basically put together to regulate testing under normal circumstances. So we don't want snake oil salesmen, for example, just selling us tests that don't work. So it's really a really good thing. But when we move into an epidemic circumstance, it actually turns out it's putting a brake nationally and in fact internationally on what we can do. So there's a big movement now towards what's called surveillance testing. And that's where we scan as many people as possible using tests that don't necessarily have to be in a CLIA certified lab. Of course, Georgia Tech, not having a medical school, did not start out with a CLIA certified lab, but we've worked with the state over the last few months. And actually we have the first stages of establishment of a CLIA certified laboratory in place, which means that we can perform CLIA certified tests. The problem we have is that surveillance tests that would allow us to do 2,000 or 1,500 students a day require on nasal swabs, and nasal swabs are somewhat unsafe, and they're very invasive, and they're also actually very much slower to process than saliva samples. So we've committed to a surveillance testing program, but we have the problem that we actually cannot use a certified test yet. So we're working on that in the next couple of weeks, as I'll explain. So that's the FDA landmark circumstance in which we find ourselves, being able to do surveillance testing, identify cases, but not report to them, or do screening testing with a certified test, which is not yet available. So what do you do when you're faced with that situation? Well, maybe you give up, or maybe you do what Congressman John Lewis would have called create good trouble. And that's sort of what we've done. And we've gone out and we've actually spent the last few weeks talking with lawyers and getting the lay of the land in other universities to come up with a program that is meeting all requirements and will we hope, be most protective of campus. So that's the regulatory landscape. So if we now think about the types of tests you can have done. So there are basically 4 types, and I'll start with the 3 that we're not doing. So one is serological tests. So they're tests that detect whether or not your body has mounted an immune response. In other words, if you've got what are called neutralizing antibodies against the virus. That's great for telling you if you've been exposed, but it's not any good for telling us if you're currently infective. So instead, we have to have something else which detects virus actually in your body at the current time. One way to do that is antigen tests. So these are tests that detect proteins on the surface of the virus. There aren't any high throughput such tests available currently, or there's one, but we don't have that available here. Well, there might be a few, but we don't have them here. In fact, we have several faculty, MG Finn, Jen Levy, Hang Lu, Mark Sosinski, and others working on such tests, but they're not quite yet available. The third type is an isothermal test. This is for nucleic acids. So the SARS-CoV-2 is in fact an RNA virus, so the nucleic acid or genetic material is RNA. These are rapid and moderate complexity tests. So if you had gone behind to the CVS site on campus in the last couple of months, this would have been an isothermal test. It takes about 20 minutes to give you a result. STAMPS has bought one of those machines, and they are able to process about 25 tests a day. But as you can see, 25 is 2 orders of magnitude less than where we'd like to be. So instead, we're going to do the gold standard PCR test. So PCR stands for polymerase chain reaction. It's also detecting viral RNA. In fact, the first step is to convert it to DNA, and then we just do an amplification reaction, which tells us whether or not there is viral material in the sample we take from you. One of the nice things about a PCR test is it's very amenable to pooling. I'll get to in a minute, and so we can scale it. Now, the gold standard for PCR tests is a nasopharyngeal swab. So that's where you have a swab that's really poked a long way up on your nose and very, very carefully performed. It's extremely hard to do. It's extremely invasive. And it turns out that they are actually transferred into something called a viral transfer medium, which actually preserves live virus. So it's got to be handled with a lot more caution. Saliva tests, by contrast, are much easier to collect. We can process them at about 10 times the rate just because of the way that they're accessioned. And they're very, very safe to handle because we, in fact, have an inactivation buffer that kills the virus immediately. The problem is that we don't yet have an approved authorized test that we can do at scale with saliva. That may change as soon as 2 or 3 days from now. In fact, we're fairly confident we'll be able to submit an EUA for using saliva by the end of the week, and that's plan A, is to do that. But as of now, that test is still a few days away. In any case, we're aiming for 1,300 to 2,500 saliva surveillance tests per day on campus. We won't be at 2,500 this weekend, but hopefully we'll be there by the end of August with all of the logistics and commitments that have been made. So I just wanted to make a comment here about accuracy. So you hear a lot about accuracy, and of course we want to have tests which are about as good as you can get. But what this slide is showing you is the relationship between cases and controls. So a case would be somebody who actually has the virus, and a control would be somebody else. And the numbers that are called positive or called negative. So in this case, I've just shown you a chart with what we might expect to see if we see 10,000 people sampled. And suppose that 100 of those 10,000, so 1%, are positive. If we have a really good test, which detects 90% of the cases, so not a perfect test, but a very good one, then we'd in fact call 90 of those cases positive, which would be true positives, and then be 10 we'd miss, which would be a false negative. By contrast, there's going to be some mistakes made. So in this case, if there's a 1% error rate, and nobody really knows what that rate is for the PCR test, but it's probably less than 1%, but say it is 1%, then in fact, of the remaining 9,900 people, 100 of them would be called positive. So a few things to notice about that. So one is that the ratio of called positive cases to controls is in fact about 50%. So in other words, there's a danger with any test that's done, and this is a very good test, you're still going to get cases, about half the people called positive actually may not be positive. So because of that, we're in fact building in a second test to really reduce that, what's called false positive rate, to make sure that you're sampled twice to reduce that. And that also helps us out by making sure that people are not isolated unnecessarily, because there's a limited number of beds that we've got set aside on campus for isolated people. The accuracy of this test is the bottom right, so that's the total number of true positives and true negatives. It's in fact 99% in this case, and that's tremendously good. If instead we tested 2,000 people instead of 10,000 with exactly the same test, same accuracy, then what we would see would be, in fact, only detecting 18 cases. So what we want is the top left number to be as high as we possibly can to filter through and trace those people and get them out of circulation. So just this slide is really making the point then that the more we can test, the more important it is. And then the second point is that the accuracy actually is not that big a deal, because even if it went down to, say, 70%, what's called sensitivity, then the ratio of positives to negatives would still be in the range of 30-40%. So high volume, frequent testing, as Joshua also remarked from his models, is really what's critical. Thanks, Joshua. Next one. Okay, so how are we going to do the sampling? So there are going to be a number of sites set up on campus, 5 eventually, but the first 2 will be at Bobby Dobbs Stadium and then up near the Student Rec Center. And there will be 12 stations at each site where there will be people manning a table, and you will be given a test kit, which will consist of a plastic bag containing a transfer pipette, that little white thing at the top is a bowl, plastic bowl pipette, a collection cup, which is kind of like the cup you get salsa in at Moe's, an alcohol pad, a sample tube, and a biohazard bag. So what you're going to do is to spit into that cup just a couple of gobs of saliva, and then you're going to use that transfer pipette to take about a quarter of a milliliter of that solution into the sample tube. And that sample tube is preloaded with an inactivation buffer called RNA-DNA shield, which immediately kills the virus. At that point, it becomes extremely viscous, so there are also some little glass beads in it, you'll notice. And what happens is, as soon as that sample gets to the lab, it's shaken very vigorously for 15 seconds, and the glass beads will break it up into a solution that's more like water. And that means it can be pipetted in a robot very, very easily. Once you're done with your sampling, you will put that back in the biohazard waste bag there, or that's not waste, it's a biohazard bag. You will swab it with the alcohol pad to make sure that there's no residues on the outside of the bag for the person who next treats it. And then you'll dispose of your samples in the other plastic bag and put them in a biohazard waste bag at the collection site. And then what we'll have you do is go to our website, which is covid19.biosci.gartech.edu, and you'll sign up. So in fact, this is changing from day to day just because of the regulations and things that we're going through. But in fact, almost all of you will in fact use the right-hand side sign up. And what we're going to have you do, wherever possible, is to sign up to get tested in advance. So there will be a calendar that you can sign into. You can register just so that we can control the flow at the collection sites. You'll be able to register at the collection site within about a 10 or 15 minute interval. And so we know how many people to expect at each site at any given time. And then you'll also take a Qualtrics survey. And that survey is going to ask you some questions, such as your age and your self-reported ethnicity and where you live and your name. And that will be regarded as invasive by some people. We understand that. So they're voluntary in the first instance because we want to sample as widely as possible. But if it turns out you're positive, you will have to give that information in the next 24 hours because the Department of Public Health, the federal government, requires all of that information. So please sign up. You'll also sign a consent document that says that you consented and have read and understood the study. And then having done that, the barcode that you will be given on your phone will be linked to your sample so that we can trace it through the system. Next. So in order to be able to do these large numbers, we need to be able to do what's called pooled testing. So a pooled test, and these are not inexpensive tests either. We're trying to do it at about $10 a test. So what we can do is put 9 people in one, or some number of people. In this picture, it's showing 9 people in one test, which means that it reduces the cost to $1 a test. And then when a pool of individuals is positive, okay, then we go back and retest all 9 individuals. That's the basic idea of what's called the Dorfman design, which is being proposed at many, many different places across the country. We've actually settled on a different design, which is called Method 4 in this recent Nature article by Smriti Malapati on July the 10th. And it's a modification of the schema on the right. So the basic idea is that those 9 people can be placed in pools, in this case pools of 3, just for illustrative purposes. And then each person is tested twice. And the way we set it up is that we can deconvolute this. We can actually identify who was positive from the fact that there was only one possible person in each pool who could have been in 2 different pools of 3. In fact, we'll probably end up testing 28 people in 8 pools of 7. and that number is optimal if the incidence is just 1%. And if you calculate using Joshua's numbers, what's the likelihood of one person being positive in 28 people? And it turns out it's about 25%. So around about a quarter of our pools will be positive, and we'll be able to know immediately who's most likely to be positive in that test. If the incidence is higher, around about 2%, we'll switch to a smaller number of pools of 5, and we'll have to do more tests. And if it's really, really high, we can possibly get away with 4 pools of 3. But I think if it's that high, then we're in more trouble to begin with. But hopefully it's not that high. But you can see why it's important to test everybody right from the beginning. So then the schema then is to do this pooled testing, and then in parallel with that, what we can do is try to identify the individuals. Now, I said at the beginning of the presentation that we cannot give results of surveillance testing by federal regulations, and that's true. But what we have learned is we can do this approach. So we're performing a surveillance test. We cannot return individual results by law. So what happens if you don't hear anything from us? So what you will hear is that your test is complete. If you don't hear anything more from us, it means you probably were not in a positive pool. Okay? But it does not mean you are negative for SARS-CoV-2 in your system. It does not mean you are negative for COVID-19, and that's exactly the reason why we don't want to be able to report individual results. Why does it not mean that? Well, sometimes there's no virus in a particular sample. Maybe it's just not in that saliva sample or not in a nasal swab is actually quite a large reason for false negatives in the nasal swab sampling. When we do pooling, sometimes the signal may dilute below the detection threshold. If we want a really accurate test, we don't do that, but we feel it's more important to do a very high volume of tests. Sometimes the lab will make mistakes. We're taking every precaution with electronic tracking of barcodes and things to make sure that doesn't happen, but inevitably there will be some. And of course, it's also possible that you become positive after testing. If you feel that you've been exposed, it's actually important that you go to get your test about 4 to 5 days after that major exposure, because it's unlikely that you'll have much virus in your system for the first 2 or 3 days, okay? But that can change dramatically. So not hearing anything does not mean you are negative. However, if you are positive by our system, then we have 2 strategies to follow up. One is to retest your individual sample in our CLIA certified test lab with the original vial that we had. And in that case, once we've done that, we can inform you that you were positive, and that will be indicated in your consent document. That is predicated on us getting this emergency use authorization submitted this week for using saliva. We're pretty confident that will happen, but if it doesn't, I've just learned this morning that the Institute has purchased 30,000 Volt tests, which are also saliva-based, so it's an external company that will be able to then call you back to get Volt tests, which are a highly supervised test. And if that doesn't work, we also have the option of potentially doing nasal swab tests with an authorized test that we could also do in the CLIA lab. Okay? So if you are positive, it's likely that you'll be called back, but you won't be the only ones called back. So we would also call back a number of people in a pool to test. So you cannot infer that if you were given a positive result that you were positive, because some of the people we call back will actually be negative deliberately so that we can be sure that we're testing and retesting and getting it right. Okay, so that's why it is that it's a little bit complex. It's not as transparent and easy as you might like, but the reason for that is just federal regulations in place for good reasons. But that's our strategy, so I'll be happy to answer questions later. Joshua, back to you.
Great, thanks, Greg. And hopefully, can you hear me now, Greg, since I've
You're
been muted? Okay, great. So I began with modeling scenarios and projections that informed some of the rationale and justification behind why Greg and so many others have worked many months to try to get a large-scale comprehensive testing system in order. That is not the only thing that we can do. So before we switch over to the Q&A, we wanted to share just a few thoughts. And one of them is also going to be a somewhat technical slide, but it tells an important story. There's a notion in epidemic modeling circles of a serial interval and a notion of a negative serial interval. Now, the serial interval, you may not have heard of this. For those who do, it's the time between when the person who is the infector has symptoms to the time when the person they infect, the infected, has symptoms. And one usually expects this is positive, right? Because I show symptoms and my symptoms indicate that I may be infectious. It transmits to someone else and then they show symptoms. When people have looked carefully via contact tracing and looking carefully at epidemic spread, they find repeatedly negative serial intervals. And what that means is that the person I've infected has symptoms before I do. And what that means is that asymptomatic, pre-symptomatic, or mild transmission is real. And in addition to this negative serial interval stuff, which you can see on the A, B panels, where multiple times people show symptoms before the person who infected them shows symptoms, and estimates on the right show the same issue. This has been one of the challenges of COVID-19, that peak infectiousness is not always correlated with symptoms. It can precede it, which means that a symptom-based approach is not going to be the way, particularly in adolescents and young adults, in which there's a higher frequency of asymptomatic disease. So if someone gets infected, but they have an asymptomatic or mild case that they don't attribute to COVID-19. And then these cases can then cascade to the greater community. I want to point out two related headlines, one of which on the left, will I get COVID-19 at this party? Well, the tool that they described is one that we've developed, again, in collaboration with Cleo Andres and others, which documents the probability, the risk that one or more individuals in groups of growing sizes may have COVID-19. And extended periods indoors without masks are associated with large spreading events. At certain institutions, UT Austin for one, they've had a ban on both on and off campus parties. And I want to reiterate the fact that all the institutional efforts that Greg has described, collective efforts of many to ensure that mask wearing, face coverings are required on campuses. These efforts won't be enough on their own. We need collective efforts to make sure that these sort of high-risk gatherings don't take place. And that really is something that I think needs to be emphasized from students to students, not just from this top-down approach. And so I want to go back to the beginning, talking about this education restart, summarizing four major themes that we've covered today. First of all, the plan is to have, ideally, arrival testing for community members. Greg talked about students as an example. The intention here is to have comprehensive testing. The rationale is to reduce the number of imported cases. Larger numbers of imported cases, given widespread community transmission, means it will be very hard to stop an outbreak or even to test enough to pull out new infecteds to keep an epidemic under control. Using repeated pool testing is a strategy to scale up both within a cost-effective way, but also in terms of the time, so that we continue to remove cases from circulation. And again, that is a testing as mitigation strategy, not a testing strategy which just tells us whether or not we're doing well or poorly, but it's in the intention here is to increase the effectiveness and reduce the number of new cases on campus. The other takeaway is mask wearing. As we know, there was a large discussion and pushback from students and faculty that ended successfully with a USG system-wide mask wearing ordinance. It is important, in my view, in our view, that this is enforceable in the sense that students should not, or staff or faculty, enter a building if they do not have a mask. We really should be aiming for 100% compliance when you are around others, particularly indoors. Increased distribution of disposable masks will help. Pointing out that in Hong Kong, some studies have shown that on crowded subways, greater than 97% of individuals were wearing masks. We want to get really that high a number. It'll keep us all collectively safe. With respect to teaching, everything we've said about gatherings suggests that at the start of the fall term, online should be the default mode. Face-to-face interactions may be warranted, especially as conditions warrant, but conditions currently do not warrant it, meaning there is a significant rise in cases in Georgia. As I pointed out at the beginning, about 50% of cases have taken place in the last month alone. So we're at much higher rates than we were in March or April, which means, again, that large gatherings are not prudent. And the last thing I want to bring up is this notion of what is essential interactions and how do we balance those with risk. We want to reduce indoor gatherings whenever possible. That includes parties. This also is important when we think about equivalent substitutes. And the reason here is not only because COVID-19 sometimes has severe outcomes for younger adults, but also because as part of a community of staff and faculty, many of whom are older, many of whom have comorbidities they may not be aware of, or have family members who have comorbidities, we want to make sure that we act with empathy and devise plans to protect and respect the entire campus community. So with that, I think we've covered quite a lot today, both on the modeling side and on the testing side. And I think there's still time for some Q&A. I know that that's been going on in the background. So I'll stop sharing the screen and hopefully we can field some questions.
Yeah, so this is Todd Streelman once again. I've been looking through the Q&A, and I think there will be a couple of questions to ask Joshua and Greg. I want to be clear that there are a number of questions in the Q&A on policy, and in large part, of course, the School of Biological Sciences does not set institute policy. What I can say is that Greg mentioned, for instance, the investment and the resources being applied by Georgia Tech to get this testing effort off the ground. So everyone should feel fairly comfortable that the administration is aware of the scientific data we've talked about and that they are involved in helping to make some of this a reality. Let's see, so there are a few specific questions about whether we could estimate the number of imported cases when students come back to campus. And I know that the models you guys discussed raised various scenarios, but is there, if I could put you on the spot, Joshua, what is your best estimate of the number of cases that we will import to campus just from, say, all of us returning?
So I will try to answer that, but I will answer it not by hedging, but by saying that there is going to be uncertainty there. If we look at Georgia and think about 3,000 or 4,000 new cases reported per day, and realize that the infectious period is about 10 days, but could be longer, we're talking about somewhere between 30 to 40,000 documented cases in the state. And I'll just use that as an example. If that is a 5-to-1 under ascertainment, meaning there are 5 cases out there, which is actually conservative with respect to what the CDC said, we're talking about over 100,000 circulating cases, maybe closer to 150,000 or more in a state with around 10.5 million people. So that gets us to about 1% in a conservative estimate. And that is helpful because that says that there may be an import, if we have 10,000 people returning, of about 100 cases. Or if we went to full capacity, about 30,000, then almost 300 cases. My expectation is that because of reduced densities, that many people will not be returning to campus, or certainly not as frequently. We've reduced interactions. But I think that we should be thinking of imported cases on the order of 100 or more. It would not surprise me if we had that many positives when we do systematic testing. Now, we may be lucky, in which case we may have dozens, and that would be on the good end. But even then, if we don't take care to wear masks in common spaces, if there are large gatherings, a few can become many. And there are many examples of that. The Rutgers football team is one example. The outbreak at the YMCA in North Georgia, the Jerusalem High School example. Example after example, if we let our guard down.
Yeah, so just again in perspective of why we need to intercept early. I mean, if we start out with 100 cases and R is 1.5 without testing, that's 150 in week 1. It's 225 in week 2. It's 300 in week 3. It's 450 in week 4. It's 1,000 by week 6 of new cases. And you accumulate that over a full semester, it's catastrophic numbers. So that's why we need comprehensive surveys. Are we going to be able to see how rapidly R is changing? I mean, we're still going to have intake from Midtown, clearly, as the semester goes on, as people are interacting and going to Publix and so forth. We're going to have mitigation unfortunately, through people getting sick and removed from the system. But I think our main target is to reduce the numbers through testing and tracing, which is a very important part of this as well, which we won't discuss today. Yes, if we do comprehensive surveillance, we have a shot of actually understanding the transmission dynamics. We'll also have some granularity as to whether it's higher in different, East Campus, North Campus, South Campus dorms, off-campus students. So we'll be able to collect that information and see what the demographic distribution is and how that's changing over the semester. And that data will actually be provided on our website, which will update daily with the incidents that we're detecting.
Okay, this is a somewhat related question, and this just has to do with the frequency of the surveillance testing. And so there was a question from Joshua's slide that this may be ideal if done once a week. But there was mention that maybe practically we could get every student tested every 2 weeks. And the question is really about what are the implications of that difference?
So I will start, and then Greg, maybe you want to jump in, or do you want to start, Greg?
Mac, why don't I start, Joshua? Just practically, I think
Sure.
we're pretty confident we can do 1,300 a day starting next week. And that's amazing. I mean, it's certainly not possible with nasal swabs, but we think we can get there. We're hiring new people. It takes 3 teams of 3 people to do this, 3 technicians. So that gives you a sense of the scope of the commitment. We can get it to 2,500 a day. That's $1,250 a week, 5-day week. That's probably 2/3 of the of the campus population. So can we do everybody every week? Probably not practically, not on our current model. We'd like to be able to get there, but does we have to? It's going to depend on what R is. It's going to depend on what the initial incidence is. If we're lucky, or in fact, if we're really good, we can actually start to reduce R to less than 1 and actually get to a point where it gets down to 0.5 or something, and we can actually even get it to just a handful of cases a week. That would be the real goal.
So let me add on to that, saying that this notion of the timing is related to the etiology of the disease, meaning if an infectious period, there's a peak infectiousness of around 7 days, if we look at this, what's called the generation interval, though the actual infectious period is certainly longer, although it may not be as transmissible. And so we're trying to use testing as a mitigation strategy, which is if you test after all the infection is done, it's too late. And so there are really 2 things I want to emphasize. I hope that if we understand the rationale behind testing as mitigation, in other words, rapid testing, that be more reserve resources given precisely these efforts that Greg has pushed on, because they had the chance, with money well spent, to increase the odds of a safer return. With respect to other time frames, I want to point out that some other universities have talked about twice-a-week testing. And Dr. Ph.D. came out and said something about arrival testing recently with 14-day quarantine. Everyone is circling around this notion, but the key idea that trying to reduce the number of imported cases is key. We do that by arrival testing. It's going to be essential that arrivals and how we operate at the beginning is not business as usual. There are many barriers still left to scale up even to 1,300 per day and then to 2,500 per day. But I would hope that the test capacity that is realized becomes the guide to how people arrive, when they arrive, and how quickly we go back to having circulation on campus. Focusing on arrival testing pulls people out, repeated testing keeps it low. And if we have the test capacity, then we restrict our ability to scale up our operation.
Okay, I think we'll take one more. And I think Greg, you just mentioned that we would not be talking about contact tracing, but I think this is on a lot of people's minds. And so what are our prospects, as you have heard on campus, for contact tracing. And it's fine if you haven't heard much. This is one of the areas that has not been addressed that well in our weekly chairs meetings on these types of topics. But you are proposing ramping up testing to a large degree, and there will be contacts that need to be traced. And so what is the general idea of how this will be accomplished?
So first of all, the Department of Public Health is responsible for tracing of actual COVID-19 cases, so people who are symptomatic and go through stamps. The tracing of people who are detected with our just to be virus positive, so asymptomatics and pre-symptomatics, is a lot harder. I mean, it's 100 cases and each person has 10 possible contacts. That's 1,000 people needing to be traced. In fact, it's not hard to see a scenario under which a quarter of the student population has been exposed. So you define exposure as a 15-minute within 6 feet. That can be detected either by manual reporting, which is best, or with an app. So when people come back to campus, there will be an app they can download that they can actually get digital contact tracing. And a lot of that will be on you, right? So you will use that, you will find your own result, and then you make decisions as to what you do. And I think that's really important to emphasize, is that this is not imposed upon people, that the buy-in from the student and the staff and the faculty body into all of these methods is absolutely critical for it to working. So a lot of it's just going to be mouth to mouth and just making sensible decisions. And if you have been exposed, then self-quarantining and just taking a lot of precautions.
Can I add just one other thing there, which is that the contact tracing, whether it's by apps or even the logistics, has proved even more difficult, I would say, frankly, on some levels than these testing initiatives. And what Greg and colleagues are developing is already removing infected individuals from circulation, which can already have a mitigation. Yes, it would be better if there was already contact tracing, but once we're doing systematic testing, the question will be, do we get to the next person using a comprehensive testing system faster than we would via a contact tracing mechanism? For contact tracing to work, it must be fast. And part of how fast it can be depends on how many cases we have. Once we have a smaller number of cases, then capacity that Georgia Tech is trying to build through trained individual, but also with volunteers, that will be stretched to its limit if the epidemic grows. And it can be more manageable if it's a smaller epidemic, which again reinforces this need to test. So we haven't covered contact tracing today simply because at present, this testing strategy in and of itself, even without contact tracing, already has a mitigation intent.
Okay. It's 12:05 and our attendee number is dwindling a bit, I think, because folks have moved on to other meetings. If
Todd,
we were...
Can I make one final comment, Todd?
Yes, of course.
Sure. So I think a lot of the people are asking, why wasn't this information provided months ago from the leadership? And you know, I think it's important to realize that this is a constantly shifting landscape and that we're under very, very serious regulatory restrictions as to what we can do. And so we and other institutes have really tried to find a way around that. If you follow in the social media and the national media, there's been this switch to surveillance, which has happened in the last 2 or 3 weeks. And so the Institute didn't want to commit to saying we'll do this and do that, knowing that it was going to change. I want you all to know that the Institute is extremely strongly behind everything that's going on in terms of testing.
I'll add one other thing to that, which is the other question, whether this is being recorded and whether it will be disseminated. And my hope is that the answer is yes. I think the other important thing is that as faculty, we have a commitment to try and use based approach and evidence we have to improve this return. And I know there's been significant amount of controversy on certain issues, which haven't heard. Sometimes it's taken too long, particularly on the mask issue, for those voices to be heard. And that all is that by looking at very we have more information on what might happen, how testing can help, that would really let the return and also help and inform communities, full of engineers entrepreneurs, students who are ready and willing to hear data this that will in fact make it easier to have students interested, involved, and committed, whether it's math learning or testing. And that kind of commitment really will make this a effective strategy. Okay. I don't know if we should wrap up and we can share the link later with Blue Jeans and so on to others.
Yeah, so there have been a number of questions in the chat about whether we would post this, and Jess Hunt Ralston has suggested the places where this will be posted, including cosgatech.edu, at GT Sciences on Twitter, Facebook, Instagram, and youtube.com Gatech Sciences as a user. So this will be posted information. I think if we were in person, we'd have loud applause for Greg and Joshua, and comments in the chat suggest that this has been very helpful for many people. So again, I'm proud of our faculty and our students that have worked really hard on some of these questions, and I'm hopeful that folks who participated in this town hall have found this information to be useful. I know that many of my fellow chairs find this information useful for those aspects of policy where we have some discretion of our own. So with that, it's 12:08. Both Joshua and Greg have listed their contact information earlier in these presentations, and I think we're all available to deal with questions over the next couple of weeks. So again, thank you for everyone attending, and thanks one more time to Greg and to Josh.